welcome to Pelvic Floor Essentials Workshop. I am a sports chiropractor. If you don't know me, some of you must follow me on social media, which is how you found me. But my background is I am a really rehab-based chiropractor. You're kind of finding me here today, not in my gym, but we have like a squat rack and a treadmill and a full rack of kettlebells and dumbbells in our front space. And that's where I spend most of my time with people. And I really feel passionately about that active portion of ways that we can help people who have pain or issues. And then my passion with pelvic floor came about, I guess, oh, can you still see that okay, guys?
Yeah.
The screen shifted a little bit. So I got pregnant with my oldest, who just turned 8 last month, I guess 8.5 years ago. And I was really excited to take my strength and conditioning rehab background to really focus on the pelvic floor. Bits and pieces have come up in my education, but I've not really had a main focus there. And I dove in head first. And at first I was like, oh my God, everybody needs pelvic floor therapy. And then once I started to get going, I was like, oh my God, nobody needs pelvic floor therapy. Like there's just like any profession, there's a lot of like fear mongering around loading. And I was kind of taking my passion for lifting and active care with people and realizing like, wow, there's a lot of really crappy information here. And I dove headfirst in the research. And this is kind of a synopsis of what I've learned as it relates to loading and the pelvic floor, and how we can help people, which is really, really powerful because a lot of people who struggle with this sort of stuff are kind of like, okay, so black leggings, panty liners, make sure you pee before and after your workout. Like those are the solutions. And for me, those are not solutions. Those are Band-Aids. So we're going to jump right in today. Like I mentioned before I started the recording, we're going to go over a quick pelvic floor 101 anatomy and function. Then we're going to talk about the signs of dysfunction. So when things aren't going so well, a lot of them won't be surprises. And then we're going to talk and get moving, and we're going to go over some like kind of active interventions, body weight stuff that you can do to kind of help shift the needle on some of these things. And then of course, some time for Q&A. So jumping right in. Any questions so far, by the way, ladies? You're doing okay? Awesome. Okay, so hold on a sec. I guess that's fine. I just noticed that I can't see if people log in, but there we go. Now I can. All right. So pelvic floor anatomy. I have this lovely picture for you here to look at, but I brought my 3D, 4D model here so you can have a better idea. Your pelvic floor is essentially the group of muscles that sit covering your pelvic outlet. So this opening here is generally referred to your pelvic inlet, and the bottom of your pelvis is generally referred to your pelvic outlet. So if I then take this pelvis, this is the front view, side view. If I take this pelvis and give you that view, that's the view that you're looking at. Actually, it's this way on the image here. And anything you see in red is muscle in terms of here also on the screen as well. We don't have to go over the nitty gritty of the specific names of the muscles, but that's where they are. So if you guys in wherever you're kind of sitting, you can kind of take your hands, sit on your hands and kind of cup your ischial tuberosity. So when you kind of wiggle in your seat, you can kind of feel the ischial tuberosity bones on your fingertips. And I just want you to curl your fingertips on the inside of those ischial tuberosities. And you're right in the meat and potatoes of your pelvic floor musculature. Of course, there's some other stuff there. But if we're staying lateral to the urogenital hiatus, and that's the medical term for whether you're male or female, the space where your junk is, more or less, vulval, vaginal, penis and scrotum for the males, and then anus for everybody. If you're just lateral to that, you're in your pelvic floor musculature. All right. So that's a little bit of a lay of the land. And then our anterior and posterior boundaries are going to be our pubic symphysis, and then our tailbone in the back. And that's essentially the tissue that we're going to be focused on for today. What does your pelvic floor do? It does so much. The things that most people commonly associate it with are its support functions and our sphincter functions. So it literally, it literally holds your organs in, right? It supports, it's the bottom support of your abdomen that sits above. And you can see here the shape of these muscles. This is around the anus and the vulvovaginal space here. These muscles literally sphincter, contract, and prevent stuff from going out. They prevent stuff, they keep stuff in that we want in, and they prevent stuff from coming in if we don't want them coming in. It's also important for sexual function. Believe it or not, this is actually really new, relatively information. We just recently, in the last like 15 years, have fully mapped out the anatomy of the clitoris. And the you can see here, this blue is actually part of the clitoris here. And these muscles, so this side has the muscle peeled back. This side shows the full extent of the muscle. And you can see how the muscle wraps around the clitoral tissue. So your ability to, a person's ability to engage, contract, relax those muscles are also going to impact the physical contact of tissues with the clitoris, whether that's during penetrative sex or any kind of stimulation of the clitoris. So your ability to climax and have more or less ability with sexual functions is all going to be related to some of the ability to engage or relax those muscles. Another more common sense ones for our rehab providers is going to be pelvic stability and our strength coaches. You can see how these integrate. Here, we're looking at, this is our obturator internus muscle. This actually comes in and inserts to the same spot on the inside of the pubic ramus, which is this bone right here, that some of your pelvic floor muscles insert into. And your obturator internus is going to be a hip rotator, or as I would like to call it, like the rotator cuff of the hip. So some really close-knit relationships there as it relates to pelvic stability. Other things your pelvic floor functions with are managing abdominal pressure, breath, and circulation. Circulation is because when you contract your pelvic floor, it lifts, relax, it lowers. It literally acts like a sump pump for your lymph and blood for the lower pelvis there. So it can be really important for circulation there. And we're going to talk a little bit more about breath and pressure in a second. So we're going to keep on keeping on. This slide here, this is just a little visual. Often we hear our pelvic floor referred to as a hammock of muscles, but I really hate that analogy. It's so much more like a trampoline. It's elastic, it's reactive, it has resting muscle tone. It's not like a passive just swath of material that is a hammock that stretches when we put load on it. So keep that in mind as we move into our next kind of analogy here, or talking about function a little more. So this is my slide where I like to help people kind of understand pelvic floor function as it relates to breath. And I'm just going to make this a little bigger. There we go. So you can see some of the details here, but we're going to talk about this pretty extensively. Excuse me. So your pelvic floor reflexively is working on your breath the whole time. One of the nicknames for your pelvic floor is pelvic diaphragm, because just like your diaphragm that sits at the bottom of your rib cage, your pelvic floor is like a diaphragm for your pelvic outlet, and it reacts with breath. So on an inhale, your diaphragm underneath your ribs contracts to push your abdominal contents down, right? This increases intra-abdominal pressure and puts a downward force on your pelvic floor. Your pelvic floor reacts to that by relaxing and lengthening. And then as you exhale, the diaphragm relaxes, it takes the pressure off the abdomen, and there's a contractile recoil, again, reflexive, that happens of your pelvic floor in your exhale. And this is happening all day, every day. In just the same way, I didn't have to remind you to breathe, right? You guys have been breathing this whole time. Your diaphragm is working with your breath. Your pelvic floor is working in reaction to that. In just the same way, I can also say, okay, take a deep breath in and hold it. And that is a conscious override of the reflexive action of your diaphragm. We can also have a conscious override of your reflexive action of your pelvic floor. Okay. And that is the Kegel. Have you guys heard of the Kegel before? Okay. So the Kegel specifically refers to the concentric contraction of your pelvic floor. So as it relates to your bicep, I often like to refer to the pelvic floor as a bicep. Why? Because pelvic floor is a little taboo. Most of us spend our time ignoring our pelvic floors our entire life. We don't really connect with those tissues. Our bicep is right here. We can touch it. And also when it contracts and relaxes, we know because there's a big output, right? Our arm moves. But if I contract and relax my pelvic floor, can you guys tell what's happening right now? No, you can't, right? But this we can see. So it's much easier to relate to. And in terms of metaphors, it checks the box for me. So a Kegel or a concentric contraction of your pelvic floor is going to be a lifting of your pelvic floor or flexing your elbow, shortening those muscle fibers. Eccentric would be the lengthening, the extension of your bicep or your elbow. And that is on the inhale of the breath, there's a lengthening of that pelvic floor, right? And then isometrically, we can hold tension anywhere in that range of motion if we're really connected and aware. Just like anywhere in that range of motion, we can pause movement as it relates to our elbow with our bicep. Now we're going to essentially use this concept now that we understand exhale, contract or Kegel is our fully flexed elbow. Inhale, relax, lengthen is our extended elbow. We can use that to understand that's how the pelvic floor functions. So therefore we can load it through those ranges of motion using a number of different variables we're going to get to challenge that pelvic floor's capacity. Okay. So we're going to do a little breathing exercise here, guys. From your seated position, you can go ahead and sit on your fingertips again, find those ischial tuberosities, curl those fingertips just on the inside. And from here, I'm going to have you just kind of close your eyes and take a quiet breath. You can make it a belly breath, right? Now, when you think of your belly breath, I know you yoga teachers know what I mean for sure. I'm sure my chiropractor does too, and the other strength coaches who are going to watch this later. A belly breath, you inhale and your belly expands, right? That expansion doesn't happen just this way, but it goes down into our pelvic floor. And then on the exhale, our belly relaxes. Also, our pelvic floor lifts. So I'm going to kind of encourage you to find this sensation in your pelvic floor. So on your inhale, do you feel your pelvic floor relax? Do you feel those tissues kind of come into your fingertips a little bit? Whoop, there we go. And conversely, on the exhale, when you exhale, do you feel those tissues kind of lift and come away from your fingertips a little bit? And can you maybe give a little oomph? Can you kind of contract on that exhale? So I'll kind of give you a minute to find that. Any thoughts, feelings, questions about that so far, Tanya or Rachel?
Yeah, this is where I'm working personally. I had a lot
Okay.
of tension after my son. And so then I'm trying to get that. Oh, I can definitely
Find
feel
that.
it. Yeah,
Yep.
that's where I am at personally. But yeah, I always try. I feel like one of the things I've struggled most in my career as I've gone into rehab is that the cueing, but like external cueing, I guess. I have taken
Mm-hmm.
a few of Levinson's courses as well.
Okay. Awesome.
But yeah, so and the breathing I can do and stuff like that and get them, but it's hard without doing internal. It's hard to know if they're actually doing it.
Totally. Totally. And
So
here's the thing. I get this all the time on this one. I didn't really feel anything, or I only felt the contraction. I didn't feel the relax.
yeah,
So let's do a little experiment with the bicep, right? Close your
all right,
eyes, reach your arm out, and then flex your arm back and forth. I know you know when your bicep is working, right? It's
Yeah.
working more this way and it's relaxing this way. But based on what you actually feel in the moment with no weight at all,
Hmm.
can you even tell?
Yeah.
Not really, right? But
Yeah.
if I
Hmm.
grabbed a kettlebell over there or some weight and I did that, it would be much easier, right? That resistance
Yeah.
improves my awareness. So there's more sensitivity. And that's what we're going to get into in a little bit is when we use our body weight and use gravity and use our ability to engage and increase our intra-abdominal pressure or our abdomen. Those are all things that are going to put more pressure on the pelvic floor, which we're going to have a more of a sensation. Also, there's been some research that came out in the last couple of months that I found super relatable is some people just don't feel their muscles. That doesn't prevent them from uh, uh, being able to receive the benefits of strength training, hypertrophy, and progressive overload, and get stronger, bigger, more robust muscles. They can still have that outcome if we're challenging them appropriately, even if they don't have that internal awareness. So I will tell people with this, or another kind of external cue, maybe, or just a different cue that most people would relate to better than all this anatomy is your this for your pelvic floor is let out a fart. This is you're on a first date, hold that fart in, right? Maybe that makes a little more sense, has a more emotional connection to it than lift and lower, right? But just to review again, lift, hold it apart, lower, let that part out. Okay. And also, too, I'll say for those of us who have any kind of breathing practice, the cue for your breath work is always to your respiratory abdomen, right? Diaphragm, rather. It's never to your pelvic floor. And these have opposite functions. So after all this talk about the bicep, right? What if I just started flipping the switch and had started you having to pay attention to the tricep? Well, it has an opposite function. So this is lengthened. This is contracted. It's confusing. So if we're using the breath as a reference, sometimes that can be hard for people, especially if their whole lives they've been exhale, relaxing, and inhale, effort, right? But for the most part, what I teach with people is I do like to give them some pelvic floor cueing to help with their awareness to because I feel like the awareness piece is something where we can gain information, if not that, at least maybe they can't feel they're not very well connected to their bodies, which is going to give us information about what we can expect for bigger movements also. And that's totally fine. But if they can connect to their bodies, maybe that looks like I can only feel the contraction. But if you're not relaxing between every effort, you're not going to be able to feel the contraction. Because if you were fully contracted and then you didn't relax, and then you're not going to go anywhere. You wouldn't feel that contraction as much. So if you can only feel one side, but you feel it every time, fine. If you don't feel much, but when you do this, you notice a reduction of symptoms, which we're going to come up to in the next slide: leaking, heaviness, sensitivity, pain, fullness in the vulvar, vagina, pelvic floor itself. If any of those symptoms change, that's a good sign too. It's not. This is not our only metric, but that's a really great question. All right. So on that note,
I'll go ahead and
oh,
add.
yeah,
I don't feel it like physically with my hands, but I can
yep,
feel internally. Like I can tell when
perfect.
I'm contracting. I've always had an issue with where people will have you hold it, like do a Kegel and hold it. I
Yeah,
don't know when I'm releasing it. So it's like
yeah,
I'll
yeah,
hold
yeah,
it, but then I don't know when it stops. So it's just like starting another one.
yeah, yeah, yeah.
So yeah.
Yep. So my question for you would be like, so we're in theory you're relaxed, you engage, and then they have you hold it, and then you
Uh-huh.
can't tell if this is staying like this or if throughout the movement you're slowly losing it, right?
Yes.
And my thought process would be, um, if you challenge yourself within your tolerance, like Goldilocks principle, right? Which is something we're going to want to use for strength training anybody. Too little of a challenge, low RPE, it's not going to be enough stimulation for adaptation. Too much of a challenge, we're going to fatigue, we're going to have soreness, we're going to have increased risk for overtraining. And that
Yeah.
sweet spot is going to be just right. At the end of the day, if it's moving the needle for the metrics that you're really after, the leaking, any other kind of symptoms like that, then we're doing great.
Okay.
It is more abstract. It is harder to know. And honestly, as soon as we can get to more global kind of exercise, because just holding a weight loads your pelvic floor. Being upright against gravity loads your pelvic floor. And again, it's a muscle that is functioning all the time in the background. Like I don't feel my muscle when my diaphragm, my respiratory diaphragm, when I breathe. Like I don't really even know what that muscular sensation is to be contracted or fatigued there. And pelvic floor is really the same way. But like I know what it feels like in the rest of my body to inhale and exhale. Like I can see the ribs moving, so I have association with that. But also from a cardiovascular standpoint, like if I am sucking wind and dying at 3 miles in my run, and then I slowly build that up, and now I'm not doing so bad running 5 miles, then was I contracting or relaxing the diaphragm and the position? I don't know, but the metric that I'm after is changing. I'm not as much out of breath. Does that kind of make sense?
Yeah.
Great question though. And that's why too, like I think for you guys as like the coach, the trainer, the clinician, the leader, it's important to have this going on in the back of your head. Because just like for biceps, right? Like from a form perspective, I want to strengthen my bicep. I know that I need to strengthen through the full range of motion. If I have somebody who can't access part of the range of motion because of pain, I know that if I stay in the pain-free range of motion, I can move the needle. But the goal is still to get to full range of motion. If I want full function of that tissue, same goes for your pelvic floor. The goal is full function of the tissue. And then that metric we're looking after is a reduction in symptoms or improvement in performance. And kind of understanding that and having that in the back of our head is going to be important as a clinician. But as far as your patients and clients go, they're caring about results. And then if what's happening up here is translating to results, then that's what it's all about. So great questions, guys. Keep them coming. Hi, Sam, by the way, I saw you popped in there. We're just shouting questions out as they go if anything comes up for you. All right, so pelvic floor dysfunction. This is going to be some symptoms that are related to your pelvic floor function, right? And again, as it relates to my bicep, is it too contracted and I'm not relaxing all the way? Is it too relaxed and I'm not contracting all the way? Is the amount of resting muscle tension inappropriate, right? Maybe I'm lifting a 5-pound weight, but my muscle is contracting like I'm lifting a 45-pound weight. That's inappropriate. And we know for your bicep with loading, we can improve range of motion, concentric strength, eccentric strength, isometric strength, we can impact resting muscle tone, all with movement and progressive challenge. So if we can do that for our bicep, we can do that with the pelvic floor. And these are some things like as coaches and clinicians, especially if you're not seeing people specifically for pelvic floor issues, these don't come up on an intake form unless you're specifically asking. And even then, as we all know, sometimes they leave it blank, right? I could be seeing someone for an ankle injury and they just leave out the fact that they had an ankle surgery 2 years ago. Like it happens. Even more so with this kind of stuff because people feel taboo or embarrassed about it. The top 5, 6 here, leaking urine. This is going to be stress and incontinence related, which is what we're going to kind of focus on here because it's likely the most common symptom that you will hear if you're training and loading someone. But you can also feel vaginal heaviness or fullness when those tissues fatigue. Vaginal flatulence. So I mentioned before, your pelvic floor's role is in support and managing abdominal pressure. We keep the stuff in that we want to keep in. We let it out when we want to let it out, and we don't let stuff in, right? If we don't want it in there. And queefing can happen when we're not regulating muscle tone in the pelvic floor. And when we move around, our abdominal contents shift, creates a vacuum and sucks in a bunch of air. And those tissues, if they have an appropriate amount of muscle tone, you can have your abdominal contents shift around, but the tension in those muscles aren't going to allow air to come in. And we can have, and if they're not doing their job, air comes in, and eventually when those organs shift back, we can have queefing. So that's the one there. And for males, they're not going to have queefing, but they can absolutely have gas on a 1 rep max, or are their working set, or their if they're going to failure or fatigue. They can notice that some of those types of symptoms. So this is not just for your female patients or your patients with uteruses. Tampons that dislodge or fall out, pelvic floor tension, where is maybe being fatigued by the tampon in there, and the again, length tension relationship is not so optimal. And then these are some other ones down the list that are not quite as objectively like musculoskeletal, but they're all related to the function of those muscles. Are they constipation, for an example? I always recommend, if that's the main thing they're asking you about as it relates to pelvic floor muscles, step one is to get them in front of an RD. Pelvic floor musculature is related to constipation, but the type of constipation would matter. If you're only pooping once every 4 or 5 days and it's tiny little hard poops, this is definitely more of a RD GI issue. And if you're pooping regularly, but you're having what they call pencil poops, right? Really thin, long poops, or you're not able to fully void, that type of constipation could be more muscular related, where your pelvic floor is literally creating an obstruction there. Or your inability to relax is creating, or lengthen is to create an obstruction there. Again, we already talked about the inability to orgasm or difficulty there. Sensation around vulva. And then, of course, at the other extreme would be too much sensation, pain with sex, vulvar pain in general. We talked a little bit about bowel movements. The circulation one that we talked about already, that has a big role in erectile dysfunction. So kind of connecting with those tissue there can also help a lot with symptom management from that perspective. All right. And now, like I mentioned to you guys at the start of that list, the stress urinary continence bit is what we're going to hear about in the gym, if that, right? And I hear a lot from my male trainer colleagues that nobody tells them. What do you mean? I know my clients don't leak. I don't know. That doesn't happen. I promise you it's happening. This was a study that came out in 2024 about the prevalence and normalization of stress urinary incontinence. And it found that 59% of female strength athletes experience stress urinary incontinence, that's SUI, during regular training. What? You guys, that's redonkulous. Okay? If you don't know about it, it is happening. Period. Now, how do you bridge the gap to be able to talk about this stuff? That's a really good question. I think building rapport with your patients, I think asking about it, I think having conversations about this when you're working with people newly postpartum is something that you can do as well. I do get that for my male coaches and trainers working with female clients that are experiencing this, it's going to be a little bit harder. You're going to have even more challenge to build up the rapport. But I just urge you, if you have an intake form or you're not asking about it directly, put it on there. That's going to be a way for them to introduce the idea without having to say it out loud and start there. But it's really important. And then even more important, the next point here from this study is that while 60% of people are dealing with this, only 9% reported treatment, and 67% of them thought it was normal and not something that they needed to address. Like, so not only is this something that you can address, but you can impact it and manage these symptoms. Okay. Why? Because skeletal muscle, which is what your pelvic floor is fundamentally adaptable, right? This is why strength training exists, for the concepts of progressive overload and SAID principle from the exercise science side of things. Specific adaptation for imposed demand. This is the idea that if I am trying to develop strength in my client, I can pick a certain type of program, certain type of loading, certain type of exercises, and those exercises are going to give me strength outcome. Or I would choose something different for endurance or speed or reactivity or coordination or relaxation, lengthening, range of motion. What are we working on, right? And as it relates to the pelvic floor, we have the ability to train all of these in the pelvic floor as well. It's fundamentally trainable. It also means if you don't use it, you lose it, right? If we're not loading, and this doesn't mean if we're not Kegling, right? Gravity loads our pelvic floor. Picking up a weight loads our pelvic floor. If you've never done a Kegel in your life, but you're strength training, guess what? You've been training your pelvic floor. Okay. So it's fundamentally adaptable. As trainers and coaches and clinicians who load people, you're perfectly primed to have an impact on these symptoms. But how does it work, right? So why do these symptoms happen in the first place? How do we know what to do, where to start? For me, the answer to this is it's a capacity versus demand issue. And this is kind of the crux of how my brain works with all of these problems. Whatever your symptoms are, leaking with exercise, fullness, heaviness, fatigue, tailbone pain, these symptoms are going to be an indicator of what your capacity is. Now, what is capacity, right? Your capacity is the maximum amount of output that can be produced with available resources. What does that mean in normal people talk, right? I'm training for a 10-mile run at the end of the month. I've been working up to 10 miles. Those are challenges that are within my capacity, right? But fundamentally, my capacity is adaptable. If I was not training, I would maybe be able to run 3 miles without dying. Also, the Boston Marathon is this weekend. 26.2 miles is absolutely outside of my capacity. As it relates to my cardiovascular capacity, running capacity, that's what I can tolerate. Okay. The demand is the challenge at hand. So if I can run 10 miles, because I'm prepared for this run to come in 2 weeks, if I want to be able to run 26.2, that's my goal, or demand is another way to kind of say goal, then that is, or the challenge at hand, then this is the gap that I have to fill. So I'm always looking to figure out what is my person's capacity. Are you leaking with exercise on the very first jump? Are you leaking with exercise not in regular jump rope, but only in double unders? Are you leaking with exercise? You feel fine when you run, but as soon as you have to run downhill, leaking. You feel fine when you run, but when you increase the pace faster than 6, 7, 8, well, I don't know who can do 6 miles, 6-minute miles, but God bless. When you increase the pace, that's increasing the ground impact forces, which is going to increase the downward pressure or the load on the pelvic floor. From that perspective, the downhill running increases downward pressure or load on the pelvic floor. The double unders are going to increase impact on the pelvic floor. If I can squat with 20 pounds, no problem. But when I squat with more than 40, leaking. That's a strength issue. I only leak during the second half of my workout. That's an endurance issue. The capacity is not meeting the demand at hand, or at the demand as part of the task. And if we can understand what we can do, right? I figured out that I can't squat with more than 40 pounds, but I can squat with 20 pounds. And we know with progressive overload, if I can do the 20 with no symptoms, increase the weight. Do that with no symptoms, increase the weight. And we can slowly close that gap to meet the demand and the task at hand. And the goal, as it relates to our pelvic floor, is to make sure the demand, the challenges that we're going to put on our pelvic floor are always beneath our capacity. And when that switches, we have a problem, right? If our capacity is less than our demand.
I have a question since we're on that.
Yeah.
For me, I have an issue with singles, but not with double unders.
Okay.
So I'll leak with single unders, but I won't with double unders. And I've heard that that's weird. So.
Yep, it is. However, with single unders, you're going to get like the reps per minute is going to be more. right?
Yeah.
You're not going to have as much downward force and impact, but it's going to be more of an endurance challenge. My question for
Okay.
you then would be like, is it the very first jump or is it like the third set? Like if you're doing like 30 seconds or like
It's
EMOMs or
usually
HIT or
like
like,
50 in, like 50.
yep,
Yeah. So after
yeah.
a
So,
while. Yeah.
yep. So there you go. It's an endurance issue. So now we've understood. So that's your metric that you're trying to shift. You can do about 50. More than that, you have symptoms. Now, to compare to my bicep, right? If I can curl 15 pounds but 20 pounds, I like can't get it up there, right?
Mhm.
As a trainer, if you kept giving me 20 pounds, that doesn't make sense, right? I can't fully execute the rep. You need to give me something that I can execute without symptoms, which is that symptoms for me as it relates to my bicep is that I don't have full range of motion. I need to be able to fully contract and relax, right?
Mhm.
So you need to find the hardest thing I can do well. Maybe that's 18 pounds. I can get it all the way up there, right? And if it's trainable, full range of motion, relatively executing the goals of the movement and related to the goal, the demand that we can't do, which is 20 pounds, right? We're increasing weight. If we can't increase weight, maybe we're doing an extra set, more reps, right? Something to improve the tissue tolerance there. Then we're going to get there. But what often happens with pelvic floor is we ignore these symptoms and we jump. If 50 we're leaking, we're doing 60 no matter what we had in our head. That's what everybody's doing. It's part of the thing, and we're leaking every single time. And that for me is the same as the 20-25 pound bicep curl that we're not moving the needle because we're not executing well. We're overtraining every single time. We're blowing out the tissue. We're going to failure, and in this case it's not ideal. Does that kind of make sense?
Yeah.
Awesome. All right. And for me, I would totally train the exercise. Another kind of option for you might be maybe we're not doing 50 jump ropes and then stopping, but maybe we can break it up and we can do 30, pause, not as long of a pause as you would pause between like a full set, but pause, recover for a second, like a 10-second break, and then go 30 more, pause, right?
Okay.
Like this is like like for runners who are looking to increase their distance, we're going to do like pace runs and we're going to do intervals and walk run intervals. And then eventually we get to the point where we can walk less and run more and improve that. Sam, I know you know what I'm talking about. Sam works with a lot of triathletes. So master endurance trainer, coach, Cairo. All right, awesome. So a couple more slides here, and then I promise we're going to get moving, guys. So in the end, leaking urine means your pelvic floor muscles are weak. By now, you probably know that I absolutely do not think that this is true. Weak is always relative, and I actually hate that word. I don't care if I'm working with somebody who can only bicep curl 5 pounds or 45 pounds. If they're not able to do as much as their goals, that's a disconnect between their capacity of their tissues and their demands. So they're not weak. They're not meeting the demands of the task at hand, right? And because we know that the pelvic floor muscles are skeletal muscles, the capacity of the pelvic floor is fundamentally adaptable. All right. So that concludes, and as usual, I'm way more long-winded than I want to be, but I like to think we baked in a few questions there. So we'll have less Q&A at the end, but I'm always happy to stay a little longer for Q&A. And if you have to bop out right at 1, totally get that, guys. But we are now going to get on the floor and do a little bit of movement. How does that sound? Pretty good. Since stress incontinence for the people who are here is kind of the metric they're looking to impact, and endurance, we know from Rachel as a factor, we can kind of use that as a theme for what we're going to focus on. I'm going to start you with some progressive jumping exercises. And we'll do as many as we have time here for like 10 or so minutes. Just like any exercise, when someone demonstrates inability to successfully perform the movement, whether it's poor form or symptoms, right? Like they don't execute well or they're having leaking symptoms. I'm going to look at the 30,000 foot view. I want to look at overall load, recoverability. Are you fueled and well slept? Like these are the things that I'm looking to manage first, the global stuff. And then if not all of those look like they're okay, then I'm going to look at specific training variables. So caveat, this is not where I would start, but because we're here specifically to talk about the pelvic floor and some of those training variables, these are some of the variables that I can manage to increase or decrease the challenge on that pelvic floor, related specifically to pelvic floor. So downward force, abdominal co-contraction, intra-abdominal pressure, which are slightly different things, and then external load, so just any kind of weight we're holding. So with all that said, I'm going to stop my share and we're going to come down to the floor and do some planks. All right. So I'm going to have you guys on the floor and we're going to start in a beast plank. All right. I call this a beast plank. When we're on our hands and knees, we're going to tuck our toes and lift the knees an inch. And what we're going to do is we're going to take our Kegel, not your classic Kegel where we're just contracting, but we're going to pay attention to our breath. And the goal here is to contract on the exhale. All right. Don't worry about the inhale. If you can contract on the exhale each time, we know that it's happening, right? For all the reasons we already discussed. But what I'm going to have you do is tuck your toes. Inhale, relax your pelvic floor. Exhale, contract your pelvic floor. Lift your knees about an inch. And we're going to hold this. And you guys are just focused on your breath. And with each exhale, I want you to exhale, engage your pelvic floor. And we're just breathing. We're going to hold this for about 5 breaths or so. And then you can set the knees down. Awesome. So right off the bat, you probably noticed a few different things. So far, we've done this from the seated position, right? Seated, we've got gravity impacting our pelvic floor. Hands and knees, we don't. But we do have engaging of our co-contraction of our abdominals. Your abdominals, especially your lower abdominals, are synergist muscles to your pelvic floor. So like biceps and coracobrachialis. These do some similar, right? And we also talked about in the breath how the abdominals relax in the inhale, the pelvic floor relaxes on the inhale. Abdominals contract or just relax back to a neutral position, pull in a little bit on the exhale, pelvic floor does the same thing. So engaging more in here tends to get some engaging in the pelvic floor. This is another great cue for people who just cannot have any sensation to their pelvic floor. If you can have them engage their abs on the exhale or pull their belly button in on the exhale, or just tighten up the pressure on their abs, this is a great tool. And it often happens reflexively. So if you go ahead and tuck take your fingertips and put them into the front of your abs, just in front of your ASIS here, and do a quick, what I call a birthday candle breath, where you're trying to blow out birthday candles. You're going to feel those muscles in your abs reflexively pop into your fingertips, right? Those muscles are contracting. Your pelvic floor is doing the same thing. And if the stimulus, the downward pressure of your diaphragm or the contraction of the abdominals, to relax your diaphragm, to exhale air out quickly, if that increase in abdominal pressure or co-contraction of the abs is not overpowering your pelvic floor is going to lift. If it is overpowering your pelvic floor, maybe you're not going to lift. Maybe you're going to experience symptoms. Maybe your sensation of vulvar fullness is going to get worse. Okay, but that's another kind of cue you can use if the relax, let a fart out, contract, hold a fart in doesn't make great sense to you. All right, how to go for the plank so far? Pretty good? Okay, so beast plank, when our hands and feet are closer, has a lower intensity challenge to that co-contraction of the abs, so therefore a little less pressure on our pelvic floor. compared to when our feet are farther away in a high plank. All right, so let's do the same thing. Inhale, relax, exhale, contract as we hold our high plank. And again, if you can't think about the pelvic floor, you can think about the abs. So contract the abs a little bit more on the exhale, relax on the inhale. And just like I mentioned too, we're going to do 5 of these guys, 5 breaths. And just like I mentioned with talking about the bicep earlier, if I have no dumbbell in my hand, I might not have any sensation in the bicep when I contract and relax. When I have weight in my hand, I might have more of a sensation. Also, if I have weight in my hand at the end extension of my elbow, I'm not fully relaxed, right? Same thing with your abs. When we're under tension in plank, when you relax, you're not fully relaxed, right? It's always relative. Your tissues are always meeting the demands of the task at hand. And this is important for any muscle, especially in your pelvic floor. And if you're getting increased tension or tighter, more muscle fatigue as you go, like this is an inappropriate relationship between your pelvic floor and the task at hand. So sometimes doing less is the cue, not doing more. Sometimes we actually cue the inhale, the relaxed part of the motion, then the contract. But we always want to do just enough, the minimum effective dose to get by. I'm guessing that all went pretty good so far,
Yeah.
right? Okay, next we're gonna have our first jumping exercise. So we're gonna start to add a little bit of impact, and we're gonna do it in a position with gravity completely removed. We're horizontal. We do have some challenges to the pelvic floor where we're breathing a little bit differently. Our abs are co-contracted, so intra-abdominal pressure is up a little bit. And I call these plank jumping jacks, okay? So from that high plank, we're gonna have our feet together. And the goal in terms of any kind of pelvic floor cueing I would cue with this is just to exhale when your feet hit the ground. At this point, I don't want you to think about exhale and contract. That's too much to think about. I just want you to think about exhale when the feet hit the ground. So it'll be like this. If your feet are like my hands hitting the ground. And because we know, we just felt in our abs, when I exhale, I felt my abs flick into my fingertips. My pelvic floor is very much likely doing the same thing, unless I'm not seeing the change in my symptoms the way that I want. Okay. So assuming all that checks out, we're on the hands, we're in a high plank, feet are close together, and we're gonna hop for 10. Feet together and then feet wide, feet together and feet wide. So awesome. How'd that go?
Good.
Pretty good? Okay. So now we're gonna start, assuming this is well tolerated, right? And this is the same thought process with any exercise, right? If I have somebody who wants to squat, that they can't squat with more than 50 pounds, they lose their form, they fall over, they drop the weight. Well, what's the thing that they can do? Maybe we have to regress them all the way back to body weight. Maybe we have to regress them all the way back to body weight in and out of a chair, right? But we slowly start there and then we build them up and we see, what are you tolerating well? And then when we find something they can tolerate well, it's like, okay, how many sets of this can you do before you fail or before your form suffers? How many reps of this can you do before you need a break, before you need to go to your next set? Like, these are just the strength training principles that apply to any skeletal muscle that we are just applying to the pelvic floor. And the variable that we're going to start to play with now is bringing gravity back into the situation, okay? So our next one, and this might be a little bit hard for you guys. I have this nice ledge here. So if you can't go this low, you could just use a wall. So you're going to be a little bit higher, but same sort of thing. If you have a middle step, take a middle step. If you don't, but we'll go. Or for those of you with walls. All right. Excellent. All right. Pretty good. Rachel, I'm guessing since you don't have issues till rep 50,
Yes.
all of this, we're not even with gravity. We're not even there yet. Okay.
Yes.
So
Yes.
let's come upright. Assuming, when would you stop with this? If I had somebody who was starting to have symptoms in these ranges, I would throw in some single leg hops, especially my runners. I would go have them switch um, to start to build in some of those running type variables before we really improve or increase gravity load on there. Some other factors that are going to play a role is if downward pressure increases the challenge on your pelvic floor, your ability to manage downward pressure matters, right? So your ability to absorb force. And let me just bring this up a little. If I jump and I don't take good advantage of my hips, knees, and ankles, and I jump like this, right? Sorry, downstairs neighbors. That's a lot of impact on my pelvic floor if I'm not absorbing that elsewhere. But if I jump and I use my hips, knees, and ankles, I'm slowing down. I'm spreading out how long my body has to respond to that force. And therefore, there's less pressure on my pelvic floor. So strengthening your ability to eccentrically load, because it's an eccentric challenge to have to decelerate quads, calves, feet, hips, then you're going to decrease the challenge on your pelvic floor. That's that capacity demand issue that we've talked about. The demand doesn't always necessarily mean change the reps, change the sets. But if you change how you execute it, you can change the relative demand on the pelvic floor tissue. Okay. Another way we can do this is, so if jumping vertically, this is going to straight up and down, is going to have the most pelvic floor challenge on these tissues for me. There is no other way for that force to go other than straight up and down, straight into my pelvic floor. But if I hop laterally, which is a little bit hard to do with a jump rope, the force starts to go like this, not necessarily straight up and down into my pelvic floor. It decreases the relative pelvic floor demand and might, if my capacity is here and jumping vertically has a demand here, but maybe I can jump laterally and it just brings the relative challenge to my pelvic floor below. Now we're in a range where the demand is slightly below my capacity and I'm going to adapt. Versus if I keep going with way too much demand where I have symptoms and I leak, then I'm not going to do well there. So lateral hops, changing the amplitude, changing the rest periods, even changing the position of our rib cage. I know we don't have time to do all these stuff, but I'm just trying to throw out some ideas for you guys in terms of, and apparently all this running training is not really helping my cardiovascular capacity the way I hoped. But these are some of the variables that you can look to change to find an appropriate challenge that is going to move the needle for you. And then it's just fundamental progressive overload. All right. Any questions, guys? We're right at the buzzer, right at 1 o'clock. How are we doing? So far, so good? Awesome.
One question that I feel like I've struggled kind of going back and forth because I've done like webinars and classes with pelvic floor therapists and then also with chiros and rehab chiros and stuff like that do pelvic floor.
Awesome.
Is the brace.
Yes.
Because it's like, you know, I see Winchester and DNS and it's like that outward movement, but then I see pelvic floor where it's like it's not belly button to spine, but it's like closing the book or, you know, that zipper up cue. And so that's where I feel like when I'm trying to teach patients how to brace, I get kind of like, what do I do?
Great question. So I might have even talked just now. I might have even said, like, thinking about pull your belly button in, mostly when I'm using the breath as a reference. and just to kind of draw sensation to that movement. But when we're talking bracing, I'm always like Winchester, DNS,
Yeah.
expanding, like you're wearing a weight belt, you're pushing out. Why? Okay, so this is the classic TVA, pull your belly button in, engagement, that the study came out in the 90s that this, and it was really flawed. If you can't do this well, you have it was associated with people who had low back pain. Okay, so then we said, oh, well, it didn't say if you strengthen this, you'll have less low back pain. It said if you can't do this well, people who had low back pain couldn't engage their TVA well. And we ran with that. Turns out, though, when we actually compared it to, so the belt, pull your belly button up and in is classically called abdominal hollowing versus the expanding out is just like a different tool, like that classic abdominal bracing. That compared to abdominal hollowing, it gets more of a robust engagement of all the muscles instead of just biasing the TVA. And then in subsequent studies, when we've actually looked at people who've gone through TVA strengthening protocols, they didn't actually see less low back pain.
Okay.
So like we had some idea of something that maybe was good from the beginning study, but then in actual execution, it didn't turn out to be what we thought it was. And then from there, bracing, especially with a breath hold, that's going to increase your intra-abdominal pressure, increase the downward forces on your abdomen. And for some people, that might increase the demand and overload their capacity. People often ask me, is bracing like just not a good idea in general? There was actually a really cool study that came out just a couple of months ago, because we used to tell pregnant people not to brace in Valsalva with heavy lifting because it was bad for baby, it was bad for pelvic floor. And this study looked at like 80% of your 1 rep max, really high RPE lifting, which we didn't have a lot of data on at all. So we would just say, maybe don't do it because we don't know. Now we know. Granted, this was a small study. I think it was only like 30 people. We need a lot more data. But we have the first study that evaluated this, and it showed totally safe for mom and baby. And again, just like anything else, saying don't Valsalva, don't brace is like me saying, don't anybody run 26.2 miles. Yeah. Well, don't do that if you can't, right? I'm training for a 10-mile run. I should not go out and run 26 miles today. But for me, 10 miles is totally within my capacity. For my last patient, they have pretty bad low back pain right now. They're not running. 10 miles would wreck them, right? What is your capacity? What is your tolerance for load? A Valsalva, a closed glottis brace does increase your pelvic floor load. If that's too much for you, don't do it. But also, if you're looking for a way to move the needle, increase the demand, I can do this exercise, but how can I make it a little bit harder so I actually have to work for it? Well, that's one great way to do it without adding reps or without adding weight or without, some of those variables. But yeah. So at the end of the day, brace, classic abdominal bracing, pushing out Q is the way I would go. Generally, I just kind of, again, use it as a teaching point, like, hey, don't worry whether you feel this or not. When you poke your abs, see how you feel that engage, it's happening already. And then with the caveat of if they're doing that and then they feel abdominal heaviness or vaginal, vulvar heaviness or fullness in their pelvic floor, like that would be a sign that they're overtraining. It's like too much of a challenge. Their demand is higher than what they can tolerate. So that can help. Kind of, and when you're those boundaries.
Okay. When you're teaching even like early postpartum, if you're teaching just being able to bring awareness back into the pelvic floor, are you having them just like the zipper up, I guess? Like that?
So I primarily, I'm going to give them an ab exercise. I probably start them in like a dead bug. Before, like a dead bug and all of those kind of exercise would be a scaled back version of a plank for me, because you're on the ground. You can really mitigate pressure. You can't go less than body weight in a beast plank, but you can go left, you can go really low weight in a dead bug, and then you can progress it. You can add weight, you can add bands, you can really make a dead bug miserable. So I start there, and I'm watching them to see that those tissues engage. I'm watching them to make sure they have good integrity of like what their spine and their rib cage is doing. I don't care if they have a rib flare or not. I just want to see that when they engage, they don't lose that even more in either direction. I want them to maintain whatever is neutral and natural for them. I don't want to create any kind of headspace around bad headspace around rib flare or not, or pelvic tuck or not. But like wherever you are, can you engage? Does it feel good? Yes. Do you feel like you're working hard? Yes. Do we have that Goldilocks challenge of not too little, not too much, that RPE of 5 or 7 out of 10? Then and they feel like they're working, great. And they don't have symptoms.
Okay.
So those are the things. And then if they really, like, again, I try not to cue the specific tissues because I find that makes people crazy. And it becomes a barrier to actually loading them, which is really the goal at the end of the day.
Okay.
So if they're seeing a reduction in symptoms and we're doing progressively harder exercises that are related to their goals, then I have no reason to cue them with a brace or a breath hold or engage your pelvic floor. But for our purposes, like, it kind of helps to know, like, this is generally what we're going for. This is generally what we're going for. So I always talk about it here, which maybe is like false advertising for how I actually work with people. But yeah, I digress.
I feel like that's going to make my job a lot easier.
Yeah. And honestly, it's like so much easier for your patients too, right? Like, I don't know about you, but like my postpartum mom brain was like,
yeah,
I can't even think about this, you guys.
Right.
Like, give me gravity. That loads my pelvic floor. I don't have to do anything, great. And I don't have symptoms, good. Okay, give me a weight. Okay, I don't have to think extra. Because after a while, it's like trying to rub your head and my brain's already doing that without having to think about movement. So yeah. All right. Well, on that note, please, if you have any other questions from this, you guys, email me. I'd love to kind of unpack some of this stuff with you. For anyone who entered today, or who signed up for our workshop for today, I am going to be doing my full, it's a paid workshop. It's 4 sessions. I do one 60-minute call like this per week. And then each week we kind of go over some of the stuff that you have questions on, that you want to work on, or again, whether it's for yourself or you have a certain patient or client in mind. I give you take home stuff, you practice it during the week, and then we report back. It's almost like a small group training kind of mentality. And I will be hosting that. It's virtual, and it will be, middle of the day, probably Monday or Wednesday in June. So if you don't follow me on social media, Dr. DRLAURALATHAM is my Instagram handle, and I'll be sharing a lot of details about that. But I'm going to give anybody who came to this 25% off for that. And if I don't know you, which I likely will, but you can just, when you sign up for that, I'll leave a spot in the notes so that we can get you a discount for that. And then I also offer a 50% off a one-on-one. This would be cash pay only, for a one-on-one session with me if you'd like to take a deeper dive and just kind of explore some of your other pelvic floor stuff, or whether that's, you take some of this, you work on it for a little bit, and then you're like, all right, I'm plateauing or I'm not progressing and I'm not sure where to go next. We can meet, and I'm happy to connect with you guys over that. And then in the meantime, like I mentioned in the email, I'm going to be sending the link for the recording for this. So if you want to rewatch, or you have more questions, you'll have that, and I'll probably be sending that tomorrow. Hopefully, that's my goal. All right. Awesome. Thank you guys so much for coming today. Again, I so appreciate my in-person guests. And thank you, all of you people who are watching asynchronously when you get there. And again, if you have any other questions, Laura@backbayhealth.com is the way to go.
Awesome.
All right. Thank you guys. Have a great day.
Thank you, Laura.